please.
Yes, as I mentioned, tonight webinar is on pediatric surgery. We have an eminent speaker from India, Professor Ravi Kanogia, and from UAE we have Dr. Diari. He's well known in Dubai and UAE. Our expert panelists, the Dr. Ayman, Dr. Kalpana, and Dr. Venkatesh in a short while. I'll be introducing them. Well, this is a picture. Friedrich Roy in 1691. He first described Hirschsprung. He was an anatomist. I would like to request you to pay attention to the clothes, the black frock coats they used to wear in those days. I will come to that then. A simple question for tonight. Who is this gentleman? I would like to request the viewer to tell us who is this gentleman and two conditions associated with his name. You will have 5 minutes time. After 5 minutes, of course, we will stop receiving the answers. At the end of the webinar, we'll announce the winner. Welcome to Dubai, the most beautiful city in the world. Those who have not seen, especially from India, we request them to come and see this beautiful city. Members of Dubai Pediatric Club, Dan, and now, well, members of the organizing committee, Dr. Joshi, past president, Dr. Kalpana Sen Gupta, secretary of the club, Dr. Diari, who is the speaker tonight, is the chairman of academic affairs, Dr. Muhammad Tulemat, Dr. Ayman Jondi, who is the panelist tonight, Dr. Rafia Ovara, Dr. Srinivas Pandari, Dr. Leila Al-Bari, and Dr. Khalid Rashid. Well, next month, we are having on Sunday, 29 August, we are having a webinar on pediatric dentistry, oral health in children. We are having eminent speaker from India, Professor Aditya Kapoor. We will have in the panel Dr. Sajjad and Dr. Saji, both consultant pediatric dentists. Details will be announced later. Well, I would like to thank Mr. Tawfiq, our sponsor, who is supporting us from beginning. He's seen here being felicitated by father of the Dubai Pediatric Club, Dr. Cyrus Letkuhi. He's always helping us. Well, I would like to give a brief account of pediatric surgery in the next 15 to 20 minutes. I'll tell you, always start with the memory of Hippocrates, the father of medicine, who said, first do no harm. And the father of Indian plastic surgery and surgery, Sushruta, and his monumental treatise surgery, which is very famous, known as Sushruta Samhita. Well, beautiful painting by Thomas Aiken is showing 1875, Dr. Samuel Gross Clinic. Look, the frock coats, surgery without the gloves. And here is Dr. Agnew Clinic, 1889. Beautiful paintings. Well, this is the era of the eater, where eater was given in the surgeries. And again, I would like to draw your attention to the type of dress without gloves. Now, in a very ancient age, in surgeries before anesthesia and analgesic, in an era before anesthesia and antiseptic, patient would experience excruciating pain, risk of infection, and even death. Surgeon wore dark, unwashed frock coats stained with blood and pus from the previous operations. Some would also keep the sewing needles stuck to the lapel of their coat. In fact, coat steeped with the dried blood could be seen as a display of their experience, and they walked bare-handed with no sterile instrument. In some London hospitals, death rate after operation was around 80%. Well, this is some improvement out there, but some of the surgeons, in order to protect themselves, they used to use the butcher's apron to protect themselves and not the patient. Well, it was Dr. William Halstead, the John Hopkins Hospital first surgeon in chief, introduced the rubber surgical gloves in the United States. That was in 1894, 5 years after the institution was opened. Here you see him, he's operating, and this was the glove used that time. But this is a very important landmark surgery in the history of surgery. I'll talk about that. That time, white gown, everything white was used, white mask, white gown, one dresses, everything to emphasize the importance of cleanliness and perhaps compensated for dim lighting. But with improvement in the lighting and using bright light, it was disturbing the surgeon's eye, everything white. So they found that green or blue color is more suiting, because it is important to know that in the spectrum of the colors, the opposite to red is green. So when surgeons, they wear the green, and when all surrounding is green, they can see better the red color. And if a surgeon is there, something that is red or pink, he becomes desensitized to it. So they are using that is by green and blue. Well, now we, Mr. Tofir, we start receiving the answers. Our answer is Dr. William Blatt, the father of pediatric surgery. Well, this is the last medal given to following generation of pediatric surgeon, and the ancient instrument about Dr. Blatt. Dr. William Blatt became surgeon-in-chief at Boston Children's Hospital in 1927 and went on to establish the first pediatric surgical training program. Lads band and lad procedure are named after him. I'm sure you know what is the lads band. Lads band, something called bands of like a fibrous stock of peritoneal tissue that attaches the cecum to the abdominal wall and creates obstruction, and this last procedure relieves that. Well, today we are talking about the surgery is the first reconstructive procedure for uretero-pelvic junction. Obstruction was performed by Turnberg in 1886. Ligation of renal pelvic first introduced by Israel in 1896 and modified by Kelly in 1906. And Lichtenberg designed the pyeloplasty in 1921. Well, Dr. Michael Harrison is considered the father of fetal surgery. Since we are talking about hydronephrosis, he founded the Fetal Treatment Center at the University of California, San Francisco in the 80s and performed the first open fetal surgery on 26 April 81, a vasectomy for congenital hydronephrosis. Well, and it was first reported in 1993 by Schuster and Associates, the laparoscopic pyeloplasty. It was published in Journal of Urology, just to remember them. Well, this is a pre-anesthesia cartoon showing surgery, and this is after that. It's the first surgery performed after giving anesthesia. You see that Dr. Warren is operating and Morton is giving anesthesia. Look at the frogs again, no gloves and no aprons. And here is Dr. William Blatt. They are the students of Dr. Lash. I would like to request all pediatric surgeons to know Dr. Dennis Brown, the father of pediatric surgery in England, Robert Gross. This is Dr. Swenson and Dr. Landman. I will talk about them. This is a beautiful photo taken in 1940 in the Department of Pediatrics. You see Dr. Ladd, and here is Dr. Gross. See how face is sad and they are apart. I mentioned about that. Here you see Dr. McCollum, Dr. Landman, and here is Dr. Swenson. I'll talk about them. Well, they are the pioneers in pediatric surgery. I'm sure pediatric surgeons, they know them. Here you see, sitting here, Dr. Ladd, Dr. Coy, Dr. Ingraham, Dr. Wyatt, and Dr. Landman. Here, this gentleman is Dr. Willis Pott. who wrote the pediatric surgery book in 1959. I would like to request you to read the preface of that book. And this is Dr. Coop. Dr. Coop, who operated in 1974, conjoined twin, very famous. Well, some of the pioneering pediatric surgeons, last recruit surgeons to do same in the acknowledged surgical specialty. Dr. Landman in urology, Ingraham in neurosurgery, Flake in otolaryngology, and plastic surgery, Dr. McCallum. Well, these two are the students of Dr. Ladd. Dr. Ladd made a school called it Boston School of Pediatric Surgery. Ladd's hands select, please note, hands select those who will spend a full 2 years exposure to pediatric surgery. Among them were two. One was Dr. Robert Cross and another one so-and-so. But I will mention after that, there was a conflict which affected the pediatric surgery in the Boston, in the United States and the whole world. Well, here in 1932, the first successful repair of the congenital diaphragmatic hernia in an infant cyanotic at birth was done by Dr. Johnson and Dr. Bauer. Now I would like to pay your attention here, please. In 1938, Dr. Gross, then a chief resident, only chief resident at Children's Hospital in Boston, ligated a ductus arteriosus in a 7-year-old girl. First successful elective cardiovascular operation in the history. Now this was done, he performed the procedure during last vacation, despite a direct order by his boss not to do the procedure. But he did it. Ladd tried to fire the Gross and eventually he succeeded Ladd as a surgeon-in-chief 2 years later when Ladd retired in 1945. From there, conflict started and the whole pediatric surgery affected. This is that 7-year-old girl, the first surgeon for ligation of the PDA. And in 1963, on 25th anniversary of the historic PDA operation, Dr. Gross united with his patients here, and it was in the Times. And Dr. Gross said, if I didn't do this operation, I would have been a farmer. Well, some of the landmark operations, the first blue baby bypass operation for tetralogy of Fallot by Dr. Walalog, Thomas, and Tossing in 1945 happened. This was a landmark operation. I'll talk about that. And the successful correction of esophageal atresia and distal tracheoesophageal fistula by Dr. Cameron Hite. You are seeing him here. The first elective operation for Hirschsprung. This is done by Dr. Swanson in 48. Here you see Dr. Swanson with this patient. I will talk about that. And the first modern textbook of pediatric surgery, abdominal surgery of infancy and childhood, was published by Ladd and Gross. But after their conflict, Gross edited the book single-handedly, and that was the textbook of pediatric surgery for a decade. And after that, others, the multi-author books came out. Now here, those who are interested in the history of Hirschsprung, I would like to mention an interesting thing here. This is Friedrich Reusch, I mentioned, a Dutch anatomist, was first to describe in 1695 the condition that today we are calling it Hirschsprung disease. This is Harold Hirschsprung. He was a Danish pediatrician who first described Hirschsprung in 2 children presented in Berlin Pediatric Conference. He didn't call it Hirschsprung, he called congenital megacolon. Interestingly, he thought that proximal part is a disease part. But later on, they came to know that no, the distal narrow part is there. And this is the Dr. Swanson. This is first patient of Dr. Swanson. Now it is interesting to know, when Dr. Swanson was working with Dr. Gross, Dr. Gross told him, you give this child to me, I will operate. But the mother of this child said, no, I will not give to anybody except Dr. Swanson. Dr. Swanson operated this child and 95% of his patients improved. And later on, he introduced a rectal biopsy for which Dr. Gross was very angry. At last, he had to leave the hospital and go to Children's Hospital, floating hospital. Now, this is that 3 people, Dr. Balalog, Vivian, Thomas, and Helen Tossing. Helen Tossing is mother of pediatric cardiology. At least we found a mother for this topic, mother of pediatric. And interesting to know, this Dr. Vivian Thomas, he wasn't doctor. He was a laboratory technician and surgical assistant. Because of his work, he was given an honorary doctorate degree from John Hopkins, and he continued to train many surgeons. He wasn't a doctor. And this is that historic operation, the first cardiac surgery operation in 1944 for Blue Baby. Well, those a lot of landmark. Thomas Landman, I was telling you, he was pioneering esophageal atresia in the review of he published review of 32 cases, all fatal. Woodworth endorsed bronchoscopy. And in 1941, as I mentioned, Ladd retired and Grass took over. And in 1948, this was Coe, organized the first professional society of pediatric surgeons that got section of surgery under the American Academy of Pediatrics. And this is a very good picture in 1960. You see Dr. Grass here, Swanson here, they are far away. I mean, they were not talking to each other. This is Dr. Willis Potts, historic picture. And this is Dennis Brown, the father of pediatric surgery in the UK, in the Great Ormond Street. This is a Great Ormond Street. Great Ormond Street was the third hospital in the world for children. The first hospital in 1802 in France, established by Laennec. Second one in Berlin, 1935. Third one, 1952. This Great Ormond Hospital, it was established by Charles West, the West syndrome we know, and Charles Dickens, the writer. And the fourth one was Children's Hospital of Philadelphia in 1855. Well, a beautiful painting showing the first appendectomy was done in London. Well, about the pediatric surgery in India, you see the picture of Professor I.C. Pathak, one of the pioneers and fathers of Indian pediatric surgery. Pediatric surgery as a specialty is about 57 years old in India. In 50s, there were only 3 general surgeons who confined their work exclusively to pediatric surgery. That was one Professor Chatterjee in Calcutta, Dr. Raman Nair in Trivandrum, and Professor Anjanulu in the Nilufar Hospital, Hyderabad. Professor Pathak, one of the pioneers, former professor and head of Department of Pediatric Surgery, former director of PGI, and he was Professor Emeritus since 1985. He has spent 12 years at Medical College Amritsar and subsequently joined about 23 years at PGI. He established pediatric surgery department at PGI in 1968, and he trained, till now 176 pediatric surgeons are graduated from PGI. Now, these are some of the you see here, Professor Pathak with Dr. Rao. Here our speaker, Dr. Ravi, is stating Professor Ram Samuj, the present professor and head of Department of Pediatrics at PGI. Here you see Dr. Ram Samuj. Here you see our speaker, Dr. Ravi, after conjoined twin operations. And here it was the first robotic surgery performed at PGI. About Dr. Rao, they are the 3 pioneers of pediatric surgery in India, Professor I.C. Pathak, Dr. Mehta and Dr. Rao, all pediatric surgeons in India must remember them. Well, this is 2017. I think this is giving a felicitation to Professor Rao. You see Professor Ram Samuj here, our speaker, Dr. Ravi, and other members of pediatric surgery. About Dr. Rao, I would like to mention here that Dr. Rao has performed more than 300 pediatric surgery for portal hypertension and more than 1,050 surgeries for the hydronephrosis, the highest in the world by any surgeon. Please note this. This is of 2017. After that, he has added many more to these figures. Well, about the pediatric surgery in Dubai, Dr. Vasavi Jauni is an extremely experienced pediatric surgeon. He undertook training course in UK before arriving in UAE in 1975. Since then, he has worked as a pediatric surgeon in renowned public hospitals such as Rashid Hospital, Dubai Hospital, and in addition to Mediclinic Wellcare Hospital, he joined, he was the head of Department of Surgery at Latif Hospital. Department of Pediatric Surgery in Latif Hospital, I think it was established in 1987. Well, this is the Boston City Hospital Operation Theater in 1880. Now, I'm going to introduce our speaker, Professor Ravi Kanodia. Everybody knows him. Dr. Kanodia is a professor of pediatric surgery at PGI Chandigarh. He has a keen interest in minimal access surgery, pediatric urology, and pediatric robotic surgery. Dr. Ravi is a member of American College of Surgeons and the Royal College of Surgeons, Glasgow. He is also the founder and editorial manager of the Journal of Pediatric Endoscopic Surgery, a Springer journal. Dr. Ravi also served as the editorial assistant for the Journal of Indian Association of Pediatric Surgeons. Dr. Kanodia currently is honorary secretary of the Indian Association of Pediatric Surgeons. He has a keen interest in teaching and has an extensive self-made library of teaching videos on the subject matter of pediatric minimal access surgery YouTube. I would like to request all viewers go to YouTube. You just write Dr. Ravi Kanodia. You will find his beautiful videos. And our next speaker, Dr. Diari. Dr. Diari Muhammad needs no introduction. Everybody in Dubai and UAE, they know him. Just for those who are joining us for the first time, I would like to introduce him. Dr. Diari is a consultant pediatric surgeon at Latifa Hospital, Dubai. He is a fellow of European Board of Pediatric Surgery and also fellow of Iraqi Commission for the Medical Specialization, especially Pediatric Surgery. Dr. Diari is the chairman of the Academic Affairs of Dubai Pediatric Club. He is a member of Iraqi Medical Association as well as member of Emirates Medical Association. He is an international and local examiner for European Board of Pediatric Surgery. So I would like to request the viewers to listen carefully. He is the examiner. So he had the post held in the Latifa Hospital since 2014, head of preventive and control of infection. He was from September 2013 to 14 chairman of the Hospital Morbidity and Mortality Committee, and since 2012 is consultant pediatric surgeon at Latifa Hospital. Well, I'm going to close. Beautiful painting again. Again, you look 100 times if I show this thing. I would like it. This is Hanuman Hospital Surgical Amphitheater in 1848. Look, as if they're watching cricket or in a football stadium. And this is the future of the operation theater. And the Hippocrates, his oath, don't forget, don't do harm. Think about that. My reference is beautiful city of Dubai. Once again, I would like to invite you to this beautiful city. Thank you very much. I end here. Now I would like to request Professor Ravi Kanodia, our speaker, to start his talk. Over to Professor Ravi. I would like to request all viewers to write their question in the question and answer box. Thank you very much.
Thank you, Dr. Saurabh. Thank you so much. I must say that I am quite overwhelmed by the knowledge of history and the presentation which you have done on the pediatric surgery history. I am sure I've never heard this kind of detailed history even from a pediatric surgeon. So this is quite overwhelming, and I mean the pictures which you showed, I have actually never seen them before. So thank you for educating us, and thank you for giving this presentation. And with that, I would again thank for the generous introduction. And I would like to address now Dr. Saurabh, the president of Dubai Pediatric Club, Dr. Kalpana, secretary of Dubai Pediatric Club, and my other fellow pediatric surgeons who are in this panel, Dr. Diari and Dr. Ayman Jundi and Dr. Venkatesh, who is a very good friend of mine. So I also express my sincere respect to this esteemed virtual audience. And I sincerely feel that this opportunity which has been given to me is an honor to be in the presence of esteemed audience. And I hope I will be able to do justice with the topic that has been given to me. So with that, with the permission of the chairman, I would like to start the presentation, and I will share my screen now. So we were in discussion with Dr. Saurabh that we need to choose a topic which has a sort of a overlap where both the pediatrician and the pediatric surgeon, they come across this condition and they treat these kind of patients in a joint manner. So there were many topics on cards, but we decided to choose the most common one, which we come across in our daily practice. And hydronephrosis, the management approach was one such topic which we unanimously agreed upon to deliberate on this. I am sure Dr. Saurabh must be remembering the combined round, which are still happening in PGI, where once in a month, the pediatric surgery team and the pediatricians, they come in the auditorium and discuss a case which has been jointly managed by the both the teams. And then they try to, study each other's perspective and the aspects and answer each other's questions so that a better management can be done to these patients. I aim to do the same thing today. So think of it as a combined round where, we are trying to understand each other's perspective and try to understand the disease for the betterment of our patients. So since hydronephrosis is a bigger umbrella, which encompasses so many other conditions, and it will encompass hydronephrosis happening because of PUJ obstruction. It can encompass vesicoureteric reflux, posterior urethral valve, megaureters, multicystic dysplastic kidneys. I thought that it will be very, very difficult if I just touch upon on all these conditions and then try to cover each and every of these conditions within this limited time period. So we decided that we'll just cover the hydronephrosis PUJ obstruction part so that a thorough understanding can be conveyed and basic concepts can be conveyed to the audience. A lot of them would be trainees and a lot of them would be early career pediatricians and pediatric surgeons. So within the scope of this presentation today, I intend to discuss the unilateral and the bilateral patient hydronephrosis. And I intend to do this through various case scenarios. So rather than putting forward plain theory in front of you, it is better to discuss case-based scenarios so that you can have a clear understanding and a more practical approach for these patients. So what would be the management approach and scheme of evaluation? What are the surgical approaches that are available for these patients? And what are the long-term follow-up strategies? So as I said that we have excluded the hydroureteronephrosis and the other causes other than hydronephrosis. So before I go on to describe my cases and then try to study the hydronephrosis, we need to first understand that what hydronephrosis actually does. So hydronephrosis by definition is the aseptic dilatation of the renal calyceal system. And this aseptic dilatation, it actually generates a cycle of stasis, infection, and back pressure changes. So whenever there is a outflow obstruction within a contained system, it will always result into stasis, and then that stasis is going to, if it continues to receive the incoming traffic, it will have a higher pressure inside the system, and it will exert a back pressure. It's a sort of a traffic jam which is happening on the road. And along with this, there would be so many parallel physiological implications for this back pressure, infection, and stasis. There would be, as soon as there is pressure is raised inside the renal pelvis, it results into renal glomerular vasoconstriction, and it raises the chances of having a tubular injury and acidosis. There can be hypertension, and then there can be renal parenchymal damage. So all these parallel effects which are happening, they are going into a vicious cycle if this kind of conditions are left untreated. So one has to be very wary, and the basic aim of treatment is to break this cycle so that that entire back pressure is relieved, infection is prevented, and stasis is prevented. So the entire physiology, the entire target of treatment is to break these cycles. So this is my index slide, the main slide, where we will be keep coming back to this slide again and again. And there are 4 index case scenarios which I have shown in this case. One is a 30, we'll start from the antenatal problems when you start getting mothers who come to you with antenatal ultrasound scans showing PCS dilatations, either unilateral or bilateral. And then as we proceed, we will take up cases of older children and other cases. So antenatal hydronephrosis, just a primer on that it is one of the most congenital genitourinary malformation which is reported on the antenatal ultrasound. And 1 to 3% of fetuses are affected by this. Majority of these cases are detected in 18 to 20 weeks of gestation, but they can be reported earlier also. So 12 weeks is the time when the fetal urine production actually starts. And by that time, once that starts happening, any kind of obstruction, if it is there, is going to lead to show up as a calyceal dilatation. So this dilatation can be because of so many reasons. So the causes are very heterogeneous. Majority of these causes which are seen early in the gestation, they do resolve spontaneously. And there can be stagnation. The hydronephrosis can happen because of the stagnation or reflux of urine in the pelvis also. So as I said, transient hydronephrosis is the most common cause of hydronephrosis, which is reported on the antenatal scans. And it accounts for more than 50% of the cases. And in majority of the condition, all you have to do is to reassure the family, reassure the mother that this is just transient hydronephrosis and it is not something bad which is happening to the child. But there are so many things which you have to take into account before you actually go and say these things to the family. The second most common cause is PUJ obstruction, which we'll be discussing today. And as I said, there are other conditions which can cause antenatal hydronephrosis, is vesico-ureteric reflux, posterior urethral valve, megaureter, obstructed variants of megaureter, and the multicystic dysplastic kidney, which can present as hydroureteronephrosis. So whenever you get a family or a mother coming to you with an ultrasound scan, most of the times we have got the habit of reading the bottom line conclusion that this has got renal pelvis dilatation and hydronephrosis is present. Cause, query, whatever they may think, they may write down that. We have to look at the ultrasound reports in a very leading manner, and a lot of times the information is missing. And a lot of time we have to send the patient back to the sonologist and ask them specific questions that, see, doctor, you have to tell us so many other things apart from the renal pelvis dilatation which is present there. So we need to know at the back of our mind that what are the things that the sonologist should actually see on the ultrasound scan whenever he is examining the patient. Anterior posterior diameter of the renal pelvis is one thing. Calyceal dilatation, whether it is there or not, what is the thickness of the parenchyma, what is the echogenicity of the parenchyma, whether it is normal looking or it is echogenic, which may or may not suggest a renal dysplasia, what is the condition of the ureter, and what is the condition of the bladder. So once you know that all these parameters are to be reported on a particular antenatal scan, you will be looking for it in a leading way in those reports, and you will be better informed, and in turn you will be able to better prognosticate the patient and talk to the family. So by definition, the normal scans, if they are less than 4 millimeters before 27 weeks of gestation, they are considered as normal. If these dimensions are more than 4 millimeter, it is considered as dilatation of the fetal pelvis. As the fetus grows, the kidney also grows. So the dimensions are also going to increase. So the metric which is taken is that if it is more than 7 mm after 28 weeks of gestation, we consider it as dilatation. And it is at that point we start, it raises a red flag in your mind and you start looking for other parameters which are described in this table. So now there are various grades which are used to define the severity of the condition. And Society of Fetal Urology in 2009 laid out grading criteria, which is very commonly followed with everybody. And it is based on the dilatation of the renal pelvis, splitting of the renal pelvis, and thinning of the renal parenchyma. So grade 1 is straightforward. There is a slight separation of the renal sinus. Ideally, this renal sinus should be collapsed and closed. But if it just appears to open a little bit, but rest of the things are normal, there are no calyces which are dilated, it is regarded as grade 1. In grade 2, you can see that the sinus, which is black in color, it has opened up a little more, and there is little extension to the calyces, but the calyces still are not dilated, and the basic architecture of the callus is maintained. So these bulbous structures are actually the calyces, which are shown to be non-dilated, seen on the ultrasound, and the renal pelvis is slightly split. So this would be regarded as grade 2. Grade 3 and grade 4 are the more severe variants, and these are the ones which should be worried for, which you can see that there is severe wide splitting of the renal sinus, but there is no thinning of the renal parenchyma, and the renal parenchyma is apparently normal in grade 3. However, if this renal parenchyma is affected and the dilatation is so severe enough that the parenchyma is thinned out, then in that case, it is regarded as grade 4, and it is the severest variant, which is often associated with severe disease, severe obstruction, and the long-term prognosis is not good. So you have to clearly lay out the grading of the hydronephrosis, which is there, should be reported. It will help you to prognosticate. So what you can prognosticate with this information is the chances of resolution. So grade 1 and 2, which are the lower grades, they will have the higher chance of resolution, more than 50%. And grade 3 and grade 4 are the one which are going to which are least likely to resolve on its own. But other than grading, there are several other prognostic indicators which you have to look out in these scans. That if there is the amniotic fluid index is less and there is oligohydramnios, it means that the kidneys are excreting lesser amount of urine and their function is compromised. It means that it is a bad kidney and things are going to be bad in future. Bright kidneys, echogenic kidneys suggest poor differentiation of the renal parenchyma, and it is suggestive of renal failure. And the other aspect is that earlier, if it is detected at less than 24 weeks of gestation, it is likely to be a severe disease. This is a generic condition. It will happen in almost any congenital anomaly, which if detected earlier in the gestation period will be more severe. So if it is not UPJO, it could be VUR and PUV. And if your ultrasound report is showing dilatation of the ureter, so you know that you are dealing with a condition where the obstruction is not at the level of the kidney, it is lower down, and either it is happening because of VUR or it is happening because of posterior urethral valve. So posterior urethral valve will have bilateral involvement and it will have dilated ureter. And along with that, there will be thick-walled bladder with the keyhole sign, which is the classic appearance of posterior urethral valve and the ballooning of the posterior urethra. This is a very ominous condition and it requires a different pathway of management and is quite difficult to treat, and it's often associated with renal dysplasia. Similarly, VUR is an entire spectrum of severity. It can range from, again, a mild grade 1 and 2 VUR, which is less severe and mostly goes away on its own, to grade 4 and 5, which is severe VUR, which can lead to infection in the postnatal period. So now the parent is asking to you, doctor, my child has got this condition, and then, what should we do? Is this a lethal condition, or is it going to have future problems? So you have to inform all this to the parents. So as I said, again, those prognostication factors, these are nearly the same points which are to be considered. What is the fetal size and maturity? Then oligohydramnios, cortical cyst. One of the objective criteria of prognosticating the fetus with severe anomalies, especially the ones who are having PUV or the ones which are having bilateral severe hydronephrosis, you have to specifically prognosticate whether these fetuses, do they require some procedure? What is going to be the outcome in future? So fetal vesicocentesis is one procedure where you sample the amniotic fluid, which is a representative sample of the fetal urine, and it estimates many components, beta-2 microglobulin and the osmolality of the fluid. It is usually done in 2 or more occasions so that you can see the difference between the two values over a period of time. And if they are decreasing, then it will suggest that the kidneys are improving. And if you relieve the obstruction early in the gestation period, they are likely to benefit from therapeutic intervention. Now, therapeutic intervention for PUJ obstruction so far has not been done in literature because the obstruction is quite high up. The kidney is located in the fetal abdomen, and mostly it is affecting one kidney only. So it is not justified to intervene in the single-sided anomaly. Vesicoamniotic shunt is one procedure which is usually done for posterior urethral valves, and it just simply bypasses the bladder outlet, which is having a physical obstruction because of the valve, and you place a tube between the fetal bladder and the amniotic fluid cavity, so that whatever urine that is coming here and exerting that back pressure changes within the bladder and back up in the kidneys, that pressure is relieved and the kidneys are able to grow. So this is the basic concept of the vesicoamniotic shunt, which is done, but it is done specifically for posterior urethral valves and not for PUJ. So postnatal management, once this child is born, mother had reported to you in second trimester, and then you kept her on a sequential follow-up, and now the child has born. What you have to do as a pediatrician? You have to suggest some investigation once the child is born. So my recommendation or suggestion for such a scenario would be that do not rush for the investigations immediately after the birth of the child. You have to first wait and watch, observe. If the baby is normal, if he's passing urine in the first 48 hours of life, he has passed meconium, there is no retention of urine, his abdomen is soft, there is no lump in the abdomen, there is no need to even do a urea creatinine within the first 1 or 2nd day, because urea creatinine done before 48 hours usually reflects the mother's creatinine level, and it would be fallacious. It is usually recommended that if you have to do an ultrasound in these patients, you better wait at least 7 days after birth, because by that time, whatever physiological fluid shifts that are happening in the newborn period have stabilized a little bit more, and the child has been feeding well. The family gets enough time to, organize themselves. Mother would get discharged by that time, and then you can ask for the investigations. So early scan, doing a very early scan within the first 48 hours is not going to help, and you will have to ultimately repeat it after 7 to 8 days again. So that is the recommendation. It is the literature recommendation also. And usually you do second ultrasound after 6 weeks of age if the initial scans are normal, because sometimes the hydronephrosis may be slow to develop. So this is a general follow-up algorithm, which I have otherwise spoken in my previous slides, that if it is of a lower grade, you just do a regular follow-up by ultrasound. Most of them would be spontaneously cured. If some of these patients are going to worsen, if they worse, they will go into this arm where we are going to describe the treatment for the severe grades. But more than 50% are going to improve on their own, and they will not require anything at all. For the severe grades, grade 3 and grade 4, you have to further investigate these patients after the initial finding of hydronephrosis on ultrasound. And this is the next investigation of choice is the diuretic renogram, which I will describe in my subsequent slides. And you have to look for the evidence of renal damage if there is an ongoing renal damage as evident on the renogram curves. And then either you keep them on regular follow-up, or you take them towards pyeloplasty because the obstruction is worsening. So all this is going to depend on what is your ultrasound finding on whether the anterior posterior pelvic diameter of the kidney is increasing, there is thinning of renal parenchyma, and the diuretic scans are showing an obstructive pattern. We will come to that in subsequent slides. So now the same slides comes back again. Now this time our child is a 6-month-old boy who has come to us with left-sided hydronephrosis. So this is a child, 6-month-old child. His presentation is actually very non-specific. 6-month-old child, if he has got a hydronephrosis, the only thing which he shows up with is he's got excessive crying. And maybe that is because of pain in abdomen, or because of that is generally he's unwell. There may or may not be a lump in abdomen, and he may or may not have recurrent pyrexia, which is not attributable to any other cause. So this is a very common condition which we come across, children of this age group coming to us with hydronephrosis, which is detected on ultrasound scan, and some cases reported on the ultrasound, which were not actually followed up properly in the subsequent scans, and then they later turn up with.
Dr. Ravi, you're not audible very well.
Okay. I mean, have I
yes,
been?
Yes, this is better. No. Just this last few seconds. Better now.
So as I said, this is a non-specific presentation, and it can be because of so many other medical causes also. But the ultrasound is going to come to your rescue, and it is going to tell whether the kidneys are normal or not. And if they report ultrasound, which is it will set off a subsequent battery of investigations which you will do. So at this time, I would take a minute to explain the pathology that is basically occurring in PUJ. Which results from the obstruction of flow, which is coming upstream from the pelvis, renal pelvis, and going down towards the ureter. The junctional part is called as the pelviureteric junction, and it is not a passive channel. It is an active channel which has got an active peristalsis in it, and it propels the urine and acts as a conduit of transfer between the pelvis and the ureter. So the pathology which is most commonly theorized is that this segment, which is the conduit in between the two areas, is becoming adynamic, and the commonest cause is that it loses its neurovascular motility and becomes a aperistatic lead pipe like thing. So there is no physical obstruction in majority of the cases. It is just that this segment is not having any kind of peristalsis, and the motor activity is absent in this particular segment. There are some rare conditions where the pelviureteric junction can be a normal segment, but it has got an extrinsic compressive cause which obstructs the flow of urine, which can be because of a vascular crossing vessel, a ureteral valve or some sort of extrinsic band or polyps. But those are very, very rare. So all we have to do is that we have to get rid of this aperistatic segment and then rejoin the thing. We'll describe that in the subsequent slides. So now this 6-month-old child, what do we do with this child? So as I said, investigations, parent is going to add what investigate. Most of the time they already come with an ultrasound in their hand, and they will ask what to do next. The most important question is going to ask, doctor, is it an emergency? And when we tell them that this is hydronephrosis, PUJ obstruction, this could be this condition, and he will require surgery, he will usually ask that, can we wait and watch? Can we do something without operating this child? So let us see if we can answer some of those questions and try to convince them. So as I said, the ultrasound, which most of the time they come with, should contain some of the basic metrics of the kidney examination. So in literature, there have been so many metrics which have been used by various authors and people. They have measured kidney with almost every angle, whether it is the anterior posterior pelvic diameter, the length of the kidney, the breadth of the kidney, the calyceal diameter, the thickness of the renal parenchyma. And then they have derived so many ratios where they have tried to do a ratio between the anterior posterior pelvic diameter with the thickness of the renal pelvis, and then they have tried to prognosticate whether this kidney is going to do well or not. So for common knowledge, I would say that renal anterior posterior pelvic diameter is the commonest metric which we use to measure the kidney. And if it is on a serial follow-up scans, this is the only value which is going to tell whether the obstruction or whether the hydronephrosis is increasing or decreasing. And it will also tell you whether the ureter is dilated or not, or whether there is a abrupt cutoff at the level of the pelviureteric junction between the PUJ and to the lower ureter, upper ureter, and is going to point towards a diagnosis of PUJ obstruction. Then the next logical investigation is the renal scintigraphy in these patients. What renal scintigraphy does is it tells you both the functional aspect of the kidney as well as the drainage aspect, whether the urine which is coming and getting filtered into the kidney, whether it is going down into the ureter or not. The three most common agents which are employed worldwide are the MAC3 scan, DTPA, and EC scan in the order of preference. MAC scan is considered the most superior, but it is not available everywhere. It is little expensive. It is good. It is got high extraction by the kidneys and it has got a rapid clearance. So it will give information about both the cortical function as well as the drainage function of the kidney. At our place in PGI, we usually use the EC scan, which gives you a fair amount of information about the drainage function of the kidney. And it tells you the level of obstruction, whether the level of obstruction is at the level of PUJ or whether it is at a lower down level. So we follow EC scan. A lot of centers do DTPA scan as well. It is matter of availability and preference. Ultimately, they all give the same information, and the information which we are looking for is how the kidney responds to the diuretic and whether the radioisotope which is getting filtered into the glomerulus ultimately passes the PUJ obstruction or not. So diuretic renography is nothing but I just call it as a toilet flush renography. So it's like a toilet where commode where you see the fluid is resting when it is not in use, and the moment you flush it, the entire bolus of fluid gushes into the outlet area, and then it momentarily pulls up. But if there is no distal obstruction, the entire fluid is cleared away, and within minutes everything washes off. But if there is a distal obstruction, this entire fluid which has been flushed because of the furosemide injection, the entire radio tracer which has been injected and has got tagged to the blood, and then it is getting filtered in the form of urine, it is going to get pooled in the renal pelvis, and then it is going to show up on the gamma camera scan and will show up as a retention of the tracer in these. So there are various protocols which are used. The nuclear medicine people have tailor-made to define and try to fine-tune and define what kind of obstruction these patients have. F0 and F-15 are the common ones which we use at our place, and F+20, some people use F+20. So what are we looking for in a renal diuretic scan? We are looking, there is a multitude of information which is given on a renal diuretic DTPA scan or a DMSA scan, MAC scan reporting. And the main thing which we are looking for is, which we have to show it to the parents, is the graph in front of us. So this is the graph which is going to happen in a non-obstructed kidney. There is a rapid, this is the graph of the gamma hits taken from the renal pelvis area, which is the gamma camera is focused on the renal pelvis and it receives the radiation from the from that particular calibrated area. So there is a rapid increase, which means that urine is getting filtered into the kidney as we give the diuretic. And then as the pelvis fills up, along with that, it immediately empties into the ureter and the gamma camera count goes down. It means that whatever flow that is happening, it is quite unobstructed and the graph is going down. This is a dilated non-obstructed pattern. This would be something in between the obstructed and a non-obstructed, where there is hydronephrosis and it is gradually the lower grade of hydronephrosis and it is gradually resolving on its own. So there would be an initial pooling and a sort of plateau, but with time and with diuretic injection, with the pressing of the commode button, the entire fluid washes away because the distal obstruction is not that, either it is very, very mild or it is not there, and the entire washout of the radio tracer is seen with this graph. This is the obstructed pattern where there is accumulation. Even the accumulation is slow to rise because the kidney function is sometimes compromised. And then once it accumulates in the renal pelvis, it will it stays there and it does not washes, and the graph does not goes down. That means the entire fluid is still there and sitting in the pelvis. It is not getting cleared in the ureter. So this is an obstructed pattern, and this is what the parent need to understand in a pictographic fashion. So the next most important question is, doctor, is it an emergency? My answer is both yes and no. For a parent, it is an emergency. He will say that my child is having kidney obstruction. The family is going to panic. But we can always tell them that, see, this is a common condition, happens it's found very frequently, and it's not a do or die situation. We have enough time to investigate these patients, properly study these patients, get all the investigations done. First, declare and confirm the diagnosis. But at the same time, we have to keep this child on regular follow-up and surveillance, because there is propensity of infection because of the stasis which is happening in the renal system. And obviously, because of the high pressure which is built up because of the obstruction, there is ongoing renal damage. And in the first 2 years of life, the kidneys are supposed to grow to the maximum. And if it is diagnosed in the first 2 years, there would, if more the treatment delay is there, the more renal growth impairment is going to be there. Is there a role of conservative management in these patients? Yes, in certain situations where the child is asymptomatic and you are presented with this kind of graph, and there is no symptom and there is no lump, and you know that these patients are going to come on regular follow-up with sequential ultrasound, which is required to document in these patients, and then there is no fall on the renal function as seen on these diuretic scans. So usually if it is a 6-month-old child showing this kind of graph, and you will be keeping this child on antibiotic prophylaxis, and these scans are repeated at an interval of 9 months to 1 year of age, and the ultrasound scans are repeated between 3 months to 4 months difference, and you keep documenting the renal growth parameters as well as the renal anterior posterior pelvic diameters, that they are not increasing, and the diuretic scan graph is showing increasing a betterment towards the normal pattern rather than going towards the diuretic pattern. So these are the cases where you would say that these kidneys can be managed conservatively, and since they are stable, there is no fall in function, we can watch them over a period of years. A lot of time, many of these patients actually don't require any surgery at all. So which is the group which will need surgery? So these are the cases where they say you see a clear obstructed pattern on the renal diuretic scan. The patient has got pain, which is the most common symptom. There may be failure to thrive. There may be evidence of recurrent infection. And sometimes these patients have absent opposite kidney, or there is a multicystic dysplastic kidney on the opposite side and hydronephrosis on one side. So if it is a single kidney patient, you have to be more aggressive and vigilant in the treatment of these patients. And in that case, you will have to relieve the obstruction anyway. So you cannot leave this group of patients alone on conservative treatment. So even on sequential scans, if it shows a decrease in the split renal function of less than 10% along with an obstructive drainage pattern, that means it is a clear indication for surgery. as is evident, the same thing would be evident by the increasing AP diameter with calyceal dilatation. And you will see that there is a gradual thinning of the renal parenchyma, which is seen on the ultrasound scan. So that is why I was emphasizing that once you are reading the ultrasound report scans, or you're reading the nuclear medicine scans, you have to go into little finer components of those reports in what they report. So you are treating this child with antibiotic as a conservative. It's a lower grade reflux, a lower grade hydronephrosis, and the child is otherwise well and asymptomatic. So does he need antibiotics? The guidelines which are existing as of now says that low grade, so SFU grades of 1 and 2, they don't require antibiotics. Many people would differ in this. They would give antibiotic to lower grades also, but the consensus majority says that they don't. For higher grades of hydronephrosis, continuous antibiotic prophylaxis is recommended. It is recommended by many associations, not just AUA, and it is prophylaxis. The commonest one which we give is Bactrim. But if there is any evidence of infection and culture positivity is there in the urine examinations, then sensitivity-based antibiotics are given to these children. So the higher grades, definitely yes, give antibiotics. So again, that same slide comes again. Now this time our patient is a 1-year-old female child, and now she's got a bilateral hydronephrosis. Now this is a different scenario, and the condition is bilateral now. This is the IVP picture. IVP is an investigation of past. We don't do it anymore now, but this is almost 10-year-old patient. When this child was 1-year-old, she had bilateral hydronephrosis. There was severe distension of the abdomen, failure to thrive, and the ultrasound was showing bilateral pelvic calyceal system dilatation, and the diuretic scan was showing bilateral obstructive pattern. His urea creatinine was on rising trend. So again, do we operate these patients urgently? Do we operate them on both sides at the same time, or they are operated at separate renal units? And how long do we, if we are doing it on separate occasion, what is the time difference? At this point of time, with the bilateral PUJ conditions, I would like to highlight that there are very specific indications of doing a VCUG. VCUG is a very invasive investigation. It's a very troubling and a torture to the child who is subjected to a VCUG investigation. So we need to know the specific instances where, in a case of PUJ obstruction, the VCUG investigation would be indicated. So if you are suspect in a bilateral hydronephrosis, you will always have to rule out intravesical obstruction. You will have to rule out vesico-ureteric reflux. So if those are the things under consideration, a VCUG investigation should be done. And if the ultrasound is reporting a dilated ureter, or if there is a evidence of duplex system in either side, an abnormal renal echogenicity and scar, which will actually will be an indicator of reflux. And there is an abnormal bladder appearance, bladder wall is thickened, bladder is tuberculated. And in those cases, these are the instances where MCU is indicated in these patients, and you should not miss a refluxing patient. So again, coming back to the scenario for bilateral PUJ, if there is the urea creatinine is normal, if we go towards this arm, the child is stable, the urea creatinine is normal, we do the VCUG, it is not showing any reflux, the diuretic scan is showing obstructive pattern, then you can offer him a pyeloplasty at the earliest available opportunity. If most of the times when these patients have a raising urea creatinine and the child is not stable, sometimes he gets infection, sometimes he is in urosepsis, then in that case, you will have to consider the possibility of doing a bilateral percutaneous nephrostomy in these patients, because before surgery, you have to stabilize these patients, and it may be a while before you can actually do that whenever there is a bilateral obstruction in these patients. And then once a PCN is done, you will do a dye study after a week, and then later consider them for a pyeloplasty. By that time, the urea creatinine would have come down, and the child would be in a much better condition to tolerate the surgery. So this particular patient, which the X-ray picture which I showed, we did a bilateral laparoscopic pyeloplasty in this patient. Both the pyeloplasties were done in single sitting, and the child did well after surgery. And luckily, he was spared of the large incisions of open pyeloplasty on either side of the abdomen, and also 2 surgeries and 2 general anesthesias. So it depends. there's nothing wrong if you do an open pyeloplasty on 2 separate occasions in a gap of say 4 to 6 weeks, with or without the cover of a PCN. It still works out well. You just have to choose whatever expertise that is available in your setup and offer that to the child. So again, the final scenario is that of an 8-year-old boy with pain in abdomen, and now this time his ultrasound is reporting right pyonephrosis. So this is another spectrum of presentation of PUJ in these patients. So there is a lump on left side of the abdomen. He's got pain, high-grade fever is there, and the ultrasound is showing dilated system with echogenic debris with renal parenchymal thickening. So now this child is a delayed presentation. He's been having this hydronephrosis for almost 8 years. He must have been stable for some time, but later the obstruction must have worsened, and then he must have got a hematogenous bloodstream infection, and then resulting into pyonephrosis. So again, is it an emergency? What is happening to his renal function? Should we do a surgery or should we do a PCN? Let's see what are the answers to these questions. So obviously we have to stabilize these patients with IV antibiotic to tackle the infection. And if there is echogenic debris, it is pointing towards severe infection. And the safest course in this scenario is to do salvage of the renal damage and do a percutaneous nephrostomy, which would provide a relief of pressure in the pelvis. It will also get you the opportunity to do a dye study through that percutaneous nephrostomy to confirm the diagnosis. So there are a lot of people who would actually do a DJ stent in these patients, or who may actually straight up, they will go ahead and operate this patient after an initial course of antibiotics. It all depends on what you're following. What I'm telling is, which is can be universally acceptable and is the least risky pathway for the patient. So most of these delayed presenting kidneys are poorly functioning. One of the most common question is asked is that now this kidney is very poorly functioned. You have done the PCN, the urine output coming through this PCN is very hypoosmolar. The volume is very less. So what should we do? So you have to, after a period of decompression of at least 4 to 6 weeks, you have to reassess whether there is recovery in the renal function or not. And this reassessment of recovery can be done by a repeat EC scan at a 4 weeks time. If you have a previous EC scan, it is good, but you will have to document the diuretic scan to see whether there is function. A DMSA scan can also be done to show the cortical function in this patient. And if there is enough function which is present, then you can offer him pyeloplasty. A lot of people would say that these kidneys are actually of no good, and they are going to eventually die off. And in fact, they will cause more problem than benefit to the patient by causing recurrent infection. They may lead to hypertension because of the non-functioning kidney. You should just take it off and do a nephrectomy. So it's all your surgical preference, what you want to do. Most of the time in the current era, people would like to give one chance through PCN drainage, prove that this kidney is worth saving or not worth saving after a PCN drainage, and then go for a nephrectomy. We published a study on the poorly functioning kidneys in 2016, where kidneys of less than 15% function underwent pyeloplasty, and majority of them actually did reasonably well, and the kidneys were spared, and a lot of them were done without PCN drainage. So one last scenario which I would like to discuss, we spoke about this thing about this solitary kidney with PUJO. So if there is a hydronephrosis and the other kidney is either absent or the other kidney is showing a multicystic dysplastic kidney, so what do we do with this kind of scenario? So here again, if the urea creatinine and everything else is normal and there is a clear obstructed pattern, there is no reason to wait. The verdict would be to go a pyeloplasty at the earliest available opportunity in these patients. Even if it is a small child, say 1 month, 3 months, or 4 months old child, even in that age range, pyeloplasty is a very safe procedure. Anesthesia is very safe. It is not that long procedure. You can always offer them pyeloplasty. However, if the child is not stable, he has already presented with high urea creatinine, and then at that case, again, you have to treat him with initial PCN drainage, and then see what is happening to this kidney. Repeat the scan, document that this kidney is functioning, and then take him for pyeloplasty after that. So some people ask that now there are so many other investigations, but I have just spoken of only ultrasound and renal diuretic scan in these patients. which provides us the maximum information that is needed. What about the role of CT and MRI scan in these patients? So most of the time when we require a CT and MRI in these patients is mostly when the structure of the kidney has got some abnormality. So either it is a duplex system, either it is an ectopic kidney, or there is this kidney is malrotated, where appropriate information is not given by the ultrasound findings, and the surgeon is not getting the mental picture of what is the shape, size, and orientation of this kidney. But when he sees the same thing on an MRI scan or a CT scan, he has got one static image in front of him, and he's able to make up a mental picture. This is a quote from one of a paper from our department published by Dr. Rao, which was on comparison the utility of MR urography in these patients. So this line says that MRI is better able to document the disorganization with loss of corticomedullary differentiation if it is there, and small subcortical cyst and T2 signal intensity, which suggest an underlying uropathy changes and permanent damage. So just by looking on the T2 images of the MRI scan, you will be able to fairly estimate and show it to the parents that this kidney is not looking good. And these are the patterns which by various measurements, software measurements on the MRI scan, the radiologist can tell that what is the functional status of these kidneys as well. So what are now the diagnosis is clear. Your whatever algorithm you have followed with all the 4 or 5 case scenarios which I had described, it is clear now this patient needs pyeloplasty, whether it's that 6-month-old child, whether that 1-year-old girl, or the 8-year-old boy. This child requires pyeloplasty. What are the surgical modalities that are available with us? The most common practice methodology is the open pyeloplasty. And then the minimally invasive pyeloplasty is now gaining momentum. It is very common. In fact, it is one of the most common laparoscopic procedure and robotic procedure which is performed. So this is open pyeloplasty, some still pictures. You can appreciate that this is the dilated renal pelvis. This is the ureter. And you can see that there is a sort of a narrowing in the ureter, which is the site of the PUJ obstruction. These are just stay sutures which are taken on the renal pelvis. This is another patient where this is the dilated pelvis. This is the ureter, and the ureter is quite narrow at a particular point, which is causing the obstruction. So now here the surgeon's job is just like a plumber. All he has to do is to cut this much part and then get rid of this bad part of the ureter and re-anastomose the normal parts to each other, so that the pipeline which is required for the flow is re-established. This picture I wanted to show, this is the anastomosis between the ureter. This is the ureter and this is the pelvis. It is in process. This is a DJ stent which we use to stent the anastomosis. You can see that this is that same tubular ureter which has been opened up. And this is, you can appreciate that this part is so narrow from inside. It is so narrow and so adynamic that it does not, even with a physical patency, it is not allowing any urine to pass through it, and thus causing the PUJ obstruction over here. This you can compare with the normal ureter over here, which looks pretty supple and quite wide. This is a view of the robotic pyeloplasty. Now we do robotic pyeloplasty very commonly. Almost 65 to 70 robotic pyeloplasty we have done in last 3.5 years. This picture is again showing the 3 robotic arms which are there. This is again, I think it's a 3-month-old child. You can see this narrow part. This is the renal pelvis. This is the left side, left colon. And we just have to get rid of this part and re-anastomose the remaining part. So it's essentially robotic pyeloplasty is a very easy and a very less morbid procedure for the patient. In an open surgery, if we do an open pyeloplasty on one side, if the patient is operated on a Monday, he goes home by Wednesday afternoon or at the maximum Thursday morning. But for a robotic pyeloplasty, if that patient is operated on a Monday morning, he can go home by Monday evening or at the maximum by Tuesday morning. So it is essentially a daycare procedure. The resumption of patient activity is very early. This is the robot which is docked onto the patient, and you can see the arms. It is feasible for small patients also. The smallest one which we have done is 58 days, and it offers you the better advantage of suturing and anastomosis, which is a little bit difficult to do laparoscopically. So what are the follow-up protocol for these patients after surgery? These patients will have stent. Most of 99% of the surgeons across the world do a pyeloplasty with a stent. There is a very few people, there are very few papers which have documented stentless pyeloplasties. These patients will have to come back for stent removal at 4 weeks, and then an ultrasound scan is repeated at 3 months, where you measure the diameter of the AP renal pelvis. So this diameter, which is measured at this 3 months post-surgery duration, it now becomes the baseline AP diameter, against which all the subsequent AP diameters will be compared when this patient comes for follow-up at 6 months or 1 year of age. We will schedule him for a renal diuretic scan after 3 to 6 months, whenever the dates are available, and try to prove that the graph, which was of an obstructive pattern before surgery, has changed to a non-retaining drainage pattern. So in long run, how do we follow them up? We usually keep calling them back for an ultrasound AP diameter assessment on a 6-monthly basis. Every year, they will get a renal diuretic scan for the first 2 to 3 years, depending upon how he is progressing. If he's doing good, we will stop at 2 years. If not, we will call him for 1 more year. And then later, he can only be followed by a yearly ultrasound monitoring, which is a very simple, inexpensive, non-invasive investigation for you to offer in the follow-up period. In general, we don't do any hematological investigations until they are indicated for any separate reason. However, at every hospital visit, we will offer to examine him with the urine routine and microscopic examination whenever he is coming to follow up for a hospital visit for getting these ultrasounds. We usually don't recommend doing a urine culture unless he's showing signs of infection. He's developed some fever, whether it is related to the urinary infection or not. If he gets a fever, he gets a urine culture just to rule out that he's not getting infection. So that's our follow-up protocol in long term with these patients. So with that, I will end my talk with some very crucial take-home messages that antenatal hydronephrosis majority resolve, the lower grades will resolve. It's only the grade 3 and grade 4 which are worrisome and should be followed up with sequential ultrasound scans both antenatally, and the patient will also need investigations after birth. So if it is unilateral, it is a very good prognosis condition, and most of the time the renal function is preserved and it is a treatable condition. If you have a child, if you are called for a child who's having antenatal hydronephrosis and is being born, do not rush for investigating him within the first 48 to 72 hours of delivery. Watch him, feed him, and let him pee first, and then see if there is any sign of urinary retention, or you suspect a posterior valve, or you suspect a bilateral condition. That is the only place where you would suggest for an early investigations. Otherwise, wait for that time. Higher grade of PUJ, once they are diagnosed, they require antibiotic prophylaxis. You cannot leave them without prophylaxis because you cannot afford to have infection in an obstructed system. Infection, as I said in the first slide, where the vicious cycle of infection, stasis, and compromising renal function is going to take a heavy toll on the kidneys. Do not hesitate to offer nephrostomy drainage if the patient presents with pyonephrosis. So late presenting patients, a lot of time, even me, I got tempted to do upfront surgery and do a pyeloplasty in these patients. They suffer post-operative complications, wound infection, and again, pyonephrosis after surgery. So do not hesitate to do a percutaneous nephrostomy. You can tell the parents that surgery in uncomplicated cases is straightforward and it requires a very short-term admission. As I said, especially with the laparoscopic procedures, it's almost a daycare procedure. And follow-up is needed for up to 3 years in uncomplicated cases. However, it may be longer in the other complicated ones. So with that, I would end my talk. And I would again thank the organizers of the entire DPC club for giving me this opportunity. Thanks to Dr. Saurabh and thanks to Dr. Kalpana. And with that, I will hand over the stage to Dr. Saurabh and Dr. Tawfiq. Back to you.
Thank you very much, Dr. Ravi, for the excellent presentation, very informative. Everybody, I'm sure they have enjoyed. Now, I would like to request our next speaker, Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Latifa Hospital, very well known in Dubai and UAE. No need for further introduction. Dr. Diari, please. After Dr. Diari, sir, I will introduce our distinguished panelists and request them to take over question and answer session. Over to Dr. Diari, please.
Good evening, everybody. Dr. Rabi, thank you very much for this nice presentation. And actually, you cover almost everything. And you make my life very easy. And then I will not be in trouble to explain and to show this all these slides. I will just go through cases, which almost you cover them. I want just to link it. I don't know if it can be seen.
Not yet.
Not yet.
Share the screen.
Just a minute, because I am not very familiar with it, to how to connect it.
Share screen.
The green button at the bottom.
The green button at the bottom. Share screen.
Just a minute. Share screen. Okay. Yeah.
In the meantime, I would like to introduce our expert panelist, Dr. Oh, yes.
Okay.
Then I'll introduce.
Just.
You can go to full screen mode.
Just a minute. I want to find it. Where is it?
Down below, down below.
Papa, do Sena. Do Sena. Look. Full screen.
You can see now?
Yeah, we can see it, yes.
So
Yeah.
my talk will be management of hydronephrosis from conservative to nephrectomy, a spectrum of pathology. As just Dr. Rafi mentioned, this is a spectrum of disease, and it presents and it is the same pathology with an excellent outcome if you are detecting it in a proper time and managing properly. So my first case will be a newborn baby born with antenatal diagnosis of bilateral hydronephrosis. So as just Dr. Rafi mentioned, the first thing, it is usually antenatally diagnosed in this place. Sometimes they might be missed, or when there is no antenatal ultrasound, then they can present later on. So this is a diagnosis, and Dr. Rafi mentioned about the SFU. Probably now you can see two on the right. On your right, there is a right kidney, which is hydronephrotic. Dr. Rafi can say that this is a SFU of grade 4. There is a really dilated pelvis, and there is a thinning of the cortex, and there is a dilated calyces. You can see this is the footprint, exactly is a footprint like picture. On the left side, you can see also the dilated pelvis and dilated calyces of the left kidney. So how we usually there is some centers they are doing in every case of bilateral or even unilateral hydronephrosis, they can do an MCUG or micturating cystourethrogram. We did for this patient MCUG, and you can see on your right hand that there is a grade 1 reflux. Do grade 1 reflux can cause this one? Most probably no. Cannot cause this grade 4 SFU hydronephrosis. Then in our protocol, after the hydronephrosis detected, the MCUG, then we will go for the isotope renal scan. When there is no reflux, then we will go for MAG3. And you can see the MAG3, how nicely showing the picture, and it is almost an obstructive pattern on the right side with hydronephrotic kidney. And even you see at the bottom post or delayed films, then you can see how bulging of the pelvis and the hydronephrotic kidney, while on the left side it is much better. Surprisingly, the function of the right and left, it's almost equal, 47 and 52 on the right side. If this is an urgent, you have to do the surgery immediately. Most probably no, because this is almost now, it is almost about 6 weeks of age. We can wait and we can, because the function is still perfect. This is an ultrasound, exactly that one was in October. If you can, it is in October, and this is in December. You can see still there is a right hydronephrosis with dilated pelvis, and on the left side, still there is hydronephrotic, but it is better, and the cortex is much, much better. We did not shift for a surgery immediately, and this is in January, almost about 6 weeks later. We repeated, still on the right side, it is hydronephrotic with dilated pelvis, and the left kidney became much better. We were going to decide this surgery for surgery of the right pyeloplasty. We said we will repeat the dynamic scan. Again, still the function on the left side is 46.6%, and on the right side, 53%. Still the function is preserved. But do you risk to continue like that? Plan to do right pyeloplasty. To be honest with you, we plan to do right pyeloplasty. Before that, we say we will repeat the ultrasound just to have a look. Surprisingly, it's almost normal. You see the right on your left hand, it's almost, which was very bad, very normal, and the pelvis, it became shrink. The left kidney, almost normal. And this is 2015. This patient, we never depend on one ultrasound. Frequently, we are repeating the ultrasound for this patient. This is in 2018. It is completely normal. So you can still have a room for conservative management, even if it is SFU grade 4. So don't rush to do surgery. My second case would be a newborn baby. Dr. Ravi also mentioned about this patient, exactly the same patient with antenatal diagnosis of left multicystic dysplastic kidney and hydronephrotic right kidney. So this is a solitary kidney. Postnatally doing well. Day 3 serum creatinine is 2.7 milligram, which is really high. First week KUB ultrasound showed. Now, if you see, I wrote first week. We never do the first day, second day ultrasound, because as Dr. Ravi mentioned, when the patient is dehydrated, then it will give you a false impression and a false reading. And I mentioned KUB because most of the people, they are requesting renal ultrasound. And when it is given renal ultrasound, this radiologist will never look at the ureter and the bladder, which should be in a protocol, KUB, kidney, ureter, bladder. This is the best ultrasound you can request. And this is his hydronephrotic single kidney, right kidney, severely hydronephrotic. You see, this is the urinary bladder, which is really very small, became, and this is a huge pelvis on the right kidney. And this is the left kidney, which you can see, this is the spleen, and this is the left kidney. So this is, you can wait on him. I don't think, especially the urea electrolyte and the creatinine is 2.7. This patient needs urgent attention. As Dr. Ravi mentioned, even if it is 2 weeks, 3 weeks, we have to do. Before that, we did the renogram, and you can see it is non-functioning right kidney with left hydronephrotic. Then we opt to operate on this patient, and we took him to OT. We did intraoperative, like MCUG and retrograde, and it shows severe PUJ obstruction. Surgery done, and this is the right kidney. This is just, you see how it became normal after the pyeloplasty, and the patient now, his creatinine is less than 1. My third case will be a 2-year-old child diagnosed antenatally as left duplex kidney with hydronephrotic lower moiety and a normal right kidney. This is another type of patients with hydronephrosis. And what we observe, although they are very less in number, that in a duplex kidney, if there is a PUJ, they are always almost of the lower moiety. We did not see, we might have 4 or 5 cases, and we saw only the lower moiety. Postnatally doing well, first KUB ultrasound showed a duplex. This is the left kidney, this is the lower moiety, and this is the upper moiety. And this is a normal right kidney. This is his DEMSA scan, which showed a good function, but you can see that there is the lower moiety is reduced function. So do you wait on this one? At that time when we were doing this one, they were not able to give us a differential function of the left kidney. The left kidney is good, but they mentioned that it is reduced, the lower moiety is reduced function. This is his EC scan, which is good drainage also, but we opt because of the lower reduced function to do the pyeloplasty for the lower moiety, and this is the left kidney almost disappeared, the hydronephrosis. And you can see it much better here that it is a duplex kidney and no more hydronephrosis, almost normal. My last case, also like Dr. Ravi mentioned, it is a 4-year-old child, which referred as an abdominal cystic mass. This child was complaining from age of 1 year as abdominal distension, and always it has been treated as gases. And this is his abdomen and his examination. You can see a palpable mass. This is my hand. And this is all occupying the right side of the abdomen. When we did the ultrasound cannot measure the cyst. It is a huge cyst and extending from the right to the left side of the abdomen. CT scan was done, and this was the cystic, which is the kidney. And you can see that this is the pelvis, which is on the right side, but this is a left kidney, not right kidney. So all what we were feeling, this was the pelvis. Do you think we can save this kidney? Most probably no. We did the DEMSA scan to make sure that this is a kidney, and exactly that was the kidney. This is the right kidney, and this is the left kidney. You can see only there is a rim of pelvis, and it was 4%. Now, as Dr. Ravi mentioned, below 10%, most of the centers, they are not keeping this kidney, and this is 4% only. And when we did the surgery, it is almost about 3 liters, 2.5 liters of urine was in that bag of, and this was the kidney, and this was the final diagnosis. Thank you very much for your attention, and this will be my last case. Thank you.
Thank you very much, Dr. Dihari, for presentation of these excellent cases. Now, I would like to request both Dr. Ravi and Dr. Dihari to join us in the panel. Now, I would like to introduce our distinguished moderators. We have 3 moderators today. Dr. Kalpana Sengupta, Senior Specialist Pediatrician at NMC Specialty Hospital. She is the head of department and secretary of the Dubai Pediatric Club. She has a special interest in urology and nephrology. Her husband is one of the famous urologists and nephrologists in Dubai and UAE. Our next moderator is Dr. Ayman Jundi, Senior Consultant Pediatric Surgeon at King's College Hospital, and Dr. Venkatesh, Consultant Pediatric Surgeon at NMC Royal Hospital at DIP. I would like to welcome all of you. I would like to request Dr. Kalpana to take over and start the panel, please.
Thank you, Dr. Saurabh. First and foremost, thank you, Dr. Ravi and Dr. Dihari, for very interesting case presentations and an excellent talk by Dr. Ravi as well. Let me begin the Q&A section with Dr. Martin's question, because this happens to relate to the terminology. So this question is to Dr. Ravi. Dr. Martin says a new consensus class nomenclature of anti and postnatal hydronephrosis has been proposed in 2017 by a group from Boston Children's Hospital. Have you applied this, and how does it compare with SFU or other concepts? What is your opinion about the value and validity of either approach, Dr.
Yeah.
Ravi?
So the SFU system came way back in 2009. And after it was proposed, as I said, that SFU was based mostly on subjective criteria. So we know that ultrasound is an observer-dependent modality. One sonologist can perceive something as a grade 1, the other one will say it is grade 2. And same way, somebody will say it is grade 3 and somebody else is going to say grade 4. There were no metrics involved. There were no numbers which were involved in the SFU grading system. And that people later on felt that it was creating more of a confusion, and it was getting difficult to prognosticate these patients, especially for the patients who were borderline ones. So that is why in 2017, this new system was proposed, where it converted from 4 to 5 grades of reflux, and then they involved all the metrics and numbers were there, and then based on that. But most of the time, our sonologists are still following the SFU grade. They would just tell us as grade 1, 2, 3, or 4. And it is actually, we just by seeing the ultrasound images, the way Dr. Diari showed those ultrasound images, we tend to draw a mental picture of the severity of the conditions. And it's not a very hard and fast fixed rules on whatever numbers that you see. A lot of things are to be correlated with the clinical condition of the child and the overall clinical scenario, which helps us to decide. So I would say that yes, this new system, the UTDs provided by the Boston group, is now catching up and is the preferred methodology over the SFU, and gradually the SFU would go away and this thing would be implemented. So we have not done any particular studies, but we do agree that this is the better and the effective way of measuring the grades.
Yeah, I would like Dr. Diari also to give his opinion on this.
No, actually, we are also on SFU. So now we are following the SFU, and our radiologists will write that the same thing.
Okay. Right.
Okay.
Yes, Dr. Ayman.
Dr. Skandarani is asking whether the MCUG is mandatory in hydronephrosis before surgery or not.
Yeah, so I would say
Okay.
specific indications where you would be prompted to do a VCUG. There are some people who would actually do a VCUG in almost every patient because they don't want to miss out on a dilated ureter. Sometimes ureter is difficult to see on an ultrasound scan. So if you are in doubt with your ultrasound reporting and you're not very confident on what has been reported, and later on if the surgeon finds during surgery that the ureter is dilated, it is very catastrophic situation for him. So that is why some out of extra caution, they will go and do a VCUG either at the time of surgery or beforehand in every patient. We usually don't do it, and we will look for the subtle signs of ureteric dilatation, recurrent UTI, and evidences of reflux, bladder dysfunction in the clinical history. If any of those things are pointing towards involvement of the lower urinary tract or the ureter, we will go for a VCUG. But not, if it's a clear case of hydronephrosis where only the pelvis is dilated and rest everything is normal, we would not do a VCUG.
Thank you very much.
Dr. Ravi and Dr. Diari, very nice presentation and it very informative. So I have a question for Dr. Ravi. So I think very few surgeons are doing robotic pyeloplasty. So what I think you've done more than 60 cases. What is your experience when comparing to open and laparoscopy and robotic outcome?
So it has been last three and a half years we have been doing robotic surgery now. We were doing a lot of laparoscopic pyeloplasties before that. And see, the idea of any surgical modality is to replicate the open procedure. Open procedure is still the gold standard. And whatever outcome and results you are getting with the open procedure, you have to replicate with laparoscopy or robotic. So in our experience, we have been able to replicate, and the success rate are same as that of an open surgery. It's all the matter of availability at your center. If you have it, you will use it. And the great advantage with laparoscopy is that we are able to send the patients home very early after surgery, and thus reducing their hospital stay and the overall morbidity with that. So robotic, yes, we are doing quite a lot now, and whether it is small patient, big patient, transperitoneal robotic pyeloplasty is now, it's actually our procedure where it's not just me, the rest of my team members, the junior ones, they are able to do that.
In relation to that, Doctor,
now,
is
if you are today, we are doing the surgery, tomorrow afternoon, we will discharge the patient again. If we are doing the surgery today morning, tomorrow afternoon, we are also discharging the patient. So it is almost 24 hours with the hospital stay.
That's correct.
Especially with a pediatric surgeon, the incision is very small, not like, you know.
That is true.
Regarding the MCUG, to be honest with you, in our center, we are doing almost for all the neonates with hydronephrosis. We are doing that. For older age, maybe no need for, as you saw. But if there is a repeated ultrasound, there is fluctuation of the diameter of the pelvis, then we are suspecting that this may be a reflux also. We are doing. The most important thing also not to miss a vesicular reflux when you are doing the MCUG is a double cycle MCUG. Most of the radiologists, they are doing one cycle and they are saying, label him as no reflux. But when you are doing double cycle, most of the time, if there is a reflux, you will detect it.
Yes, I just wanted your input on laparoscopic surgeries. As you said that more and more laparoscopic surgeries are being performed less open. Is it the same for systems which are duplex systems or more complicated systems? Do you still go ahead with laparoscopic, or you prefer to do these cases as open?
Yes, we do. We would always give an initial attempt of a laparoscopic procedure. And in a laparoscopic procedure, the basic mindset is that you go and attempt. If you are able to do it and it is technically good, you will continue doing it. If at any stage you feel that you are not able to do the procedure, there is anatomical difficulty or there is any other problem, you'll just straight away convert and complete the procedure the way you would do it in open surgery. But as a first-hand procedure, even in duplex system, malrotated kidneys, ectopic kidneys, we attempt and go for a laparoscopic approach first.
Okay, Ahmed.
Yeah. A question for Dr. Diari from Dr. Monica Bauer. If you have a patient with PUJO and vesicular junction obstruction on the same side, I suppose, which one would you deal with first?
So a double obstruction.
Yeah.
Yeah. Usually we are dealing with the upper one. Usually we are dealing with the upper obstruction.
First.
Yes.
Yeah, I hope that answers Dr.
Same for me. Yeah, same for me. We will treat the PUJ because that is the level of obstruction which is going to damage the most and produce maximum harm to the kidneys.
Actually, as per the dictum, usually
junction obstruction can be resolved, and most of them they will resolve the vesicular junction obstruction, not like the PUJ obstruction. If there is a double, and we are facing, sometimes we are facing a double obstruction.
What is your, when we are not able to pass the guide wire, we incidentally came to know that it's VUJ obstruction, then we will go with the nephrostomy, or how your approach in like kind of cases? When intraoperatively you're not able to pass the stent because of VUJ obstruction, what's your experience?
Intraoperatively, if you're not able to pass the stent, it does not means that it is a VUJ obstruction. VUJ obstruction is an entirely different condition where you will have some or the other dilatation of the ureter. So you will know that this is a VUJ obstruction. Most of the time, stent is easily passed. If it is not being passing easily through the VUJ level, it is either because of this some sort of kinking, you have to choose a different guide wire size, or the bladder is overfilled and the ureteric orifices are overstretched. Those are the few reasons which you have to look for. Even if you are not able to do with all the maneuvers, if you are not able to pass, you can always choose either for a stentless repair with a stent, with a drain, or do a percutaneous nephrostomy in the same sitting. It all depends on how you have counseled the patient. But non-passage of stent intraoperatively is not the same as VUJ obstruction. That's what I would say.
What's your opinion about same, Dr. Dairy?
Yes.
What's your opinion about this?
Yeah, it's exactly the same. If you are not able, always you can put in percutaneous, or sometimes you can do a cystoscopy, and through the cystoscopy you pass the guide wire.
Yes.
Thank you.
So Dr. Abdul Kadim has asked, what are the criteria for antenatal intervention when fetal hydronephrosis is diagnosed? So I know you, Dr. Ravi has spoken about this, just clarifying the points again.
So we really don't have any personal experience with this. Whatever we have read from the literature, I would be saying that, and that was put up on that slide, that the fetal interventions so far, which have been done in the world literature and documented there, are only for the intravesical bladder obstruction, outlet obstruction, and the PUV cases. And it is based on the findings on the assessment of the fetal urine assessment, where they have assessed for the levels of sodium and the sodium chloride, beta-2 microglobulin, and the proteins. So if they fall in a particular range over a serial estimation, they would go ahead and do a vesicoamniotic shunt. So they are just trying to decide whether it is a salvageable condition or not. If it is a salvageable condition, they would go ahead and do it. If it is not, either because of severe renal dysplasia or some other reason, they will not jeopardize the life of the mother by doing a fetal intervention. So that's the basic algorithm there.
So there was a time when fetal interventions were becoming very popular, or everybody thought that, yeah, they would progress very rapidly. What, in your opinion, is the current state, or why is it that we have found not so many cases, not so many centers using these modalities?
Yeah, so fetal intervention is a very multidisciplinary specialty, highly technical, and requires a lot of sophisticated instruments. There are a lot of ethical issues which are involved, and it is even for the best centers in the world, it is very difficult to get a patient for a fetal intervention. Very difficult to convince that the life of the mother is also jeopardized if we do this procedure. So it has to be a really dedicated mother and really precious child, where people would like to put the main member of the family at stake. And then, as I said, that there are so many teams involved, and there is a lot of training and teaching which is involved before any center can perform fetal interventions. So I believe that it is because of these reasons only the higher centers, very few in US and very few in Europe, have been able to put up fetal interventions.
Dr. Kalpana, for fetal intervention, first of all, you have to have a correct diagnosis. Second one, should be a bladder outlet obstruction. The third one, it should not be after 24 weeks before. What is the idea that this patient should be the pulmonary, the lung maturation should be finalized. So after 24, the PUJ will, the posterior urethral valve will not affect the lung. So it should be before the 24 weeks. It should be a single normal karyotype. It should not be in one, let's say, Edwards syndrome or Patau syndrome. So it should be the normal karyotype when you want to interfere with these patients. And there should be oligohydromenous. If there is no oligohydromenous, so there is no indication to do because the prognosis of the patient to be born, it will be better than, as Dr. Ravi mentioned, to life of the mother, to chorioamnionitis, to premature labor, all these are complications of, and by itself, the vesicoamniotic shunt failure rate is more than 50%. It will dislodge.
Right.
There is a question.
So there is a
Dr.
limited
Ravi.
indication for the intervention.
Sorry, there is a question to Dr. Ravi by Dr. Ahmed Itu. How often did you need to convert from laparoscopic approach to open approach in pyeloplasties?
So whatever numbers which we have with laparoscopy, I would say in the initial, say 40% of the cases, my conversion rate was close to 20%. But as our experience grew, it has come nearly to 0% now, because now the frequency of laparoscopic pyeloplasty is quite high at our center. And the conversion rate now is, I would say it is less than 2%. And that too, sometimes we have to convert either because of there is excessive bowel gas distension, or there is some anatomical problem which makes the procedure technically difficult. So in those cases, we would have to convert. Otherwise, for normal, straightforward hydronephrosis PUJ diagnosis, we do a pyeloplasty even in small child. Conversion is very, very rare. So it's all about the learning curve graph, which happens with everybody. In the initial part of our experience, the conversion rate for us was little high, close to 20%.
What would you say about the difference between the learning graph for robotic versus laparoscopic? Since your center has robotic, how long did it, was the learning curve very steep, or how was it?
It was not steep because robotic is just an extension of what you do laparoscopically with a greater ease actually. So with robotic, you have exactly the same set of instruments, but the maneuverability of those instruments is much better, and it is much easier to do the suturing and the long anastomosis inside the pediatric small abdomen. So actually, once you get a hang of the hardware, see, the problem with robotic system is that it's a big machine, big arms are there. You have to adjust them into a small pediatric abdomen. There are a lot of hardware and a lot of technicalities which are involved. So once you get a hang of it, the procedure is actually simpler to do robotically than laparoscopically. So the graph mainly, learning curve graph mainly depends upon how quickly you learn and get accustomed with the hardware of the robotic system than the actual procedure.
There is a question actually by Dr. Abul Maati, and I would direct it to both our speakers. When you consider giving prophylactic antibiotics in PUJ obstruction, how long would you use that? How long would you use antibiotics for?
Yeah, so if we are keeping the kid on conservative management, that means it is one of the lower grades, grade 1 or 2, we will not require. But if we choose to give antibiotic, we would see the progress on the ultrasound and how much he has been symptom free. I would say that for 6 weeks we put him on antibiotic, and after that we switch him off the antibiotic for another 2 to 3 weeks duration. If he remains okay for that time, there is no pain, no symptom, we may not restart those antibiotics again. But however, if during that off period, if he develops any symptoms, we would ask the parents to resume the antibiotics. So it all depends upon how he fares and responds to the stopping of the antibiotics. But once he comes to you and you have established that he needs to be not to be operated and needs antibiotic, at least 6 to 8 weeks is the time period where we will put him on antibiotics and just watch him.
Yeah, Dr. Diari.
Yeah,
What do you think?
Dr. Jundi, as we have experience of hydronephrosis, we are not seeing a UTI or urinary tract infection with hydronephrosis or PUJ obstruction. It is very, very unusual. But as Dr. Rafi mentioned, in high-grade hydronephrosis, we are putting on prophylaxis till the surgery, or the regression of the hydronephrosis. If surgery done and there is a stent, then we will continue with the prophylaxis OD till the stent will be removed. Yeah, but most of the time there is no UTI with hydronephrosis PUJ.
Yeah, so antibiotic prophylaxis are not used routinely in every case of PUJ obstruction.
No.
Yeah, only in high grade. Yes. Thank you very much.
Next question is, in case of severe hydronephrosis, what age you will prefer to do nuclear medicine scan, MAC or EC scan or DTP, whatever? What is the idea your opinion?
So that's a good question. The nuclear medicine scan has got some limitations if you do that in a newborn child. So our preference of getting a nuclear medicine scan, and the earliest time when we can do it is, the ideal would be 3 months duration. The reason being that at 3 months, the glomerular filtration rate of a newborn establishes to a near normal value. There is enough renal maturation which has happened, and the urinary osmolality is also nearly normal at that particular age group. So if you do a renal scan before that, it may be fallacious. The cortical function which it may project you in terms of the percentage function of that kidney. It may be either falsely high or falsely low. But there are people who would do it at 1.5 months of age, either because he's got a single kidney and they need to have some information about that kidney. But for a cool case where you don't have any reason to rush in, 3 months is the ideal age where you should go for a MAC scan or a DTPA scan.
So MAC scans are actually replacing DTPA scans everywhere.
Yes.
But as I remember, you said that, you could do any of these and it should be okay, depending upon, of course, the availability. But why is MAC scan better than DTPA scan?
Yeah, MAC is a better cortical agent. So that's the basic theory, that it is a better cortical agent and it has got a better cortical binding activity. So as soon as you inject it into the bloodstream, whatever those cells, they get tagged into the renal cortex and gives you a picture of the renal cortex. So the denser the picture on the scan, the better functioning kidney that it is. Okay, if you don't have any photopenic areas, you don't have any break in the outline, that means that kidney is good. And so anything which binds with the cortex and the renal cortical area is going to give you a better picture, which is better with the MAG as compared to DTPA and which are better, DTPA and EC, which are better filtering agents, which are very easily filtered into the PCS system.
In Dubai, we are doing MAC 3 only now.
Yes.
And, we can do it at the age of 1 month, and it is recommended to do it at the age of 1 month. You can do MAC 3. We have 2 cases which has been done with other material and from private. We found, as just you mentioned, the function was 20%. When we repeated that 3 months, it was almost about 45%. So when there is no maturation of the renal tissue, it might give you a false impression of the function. Yeah, you are correct.
Just to clarify, because that was done at an earlier age with another agent. That's what you mean, doctor?
Earlier agent with another agent. As it's not indicated so early if it is not really indicated.
Yes. And Dr. Ravi, you had a slide on F0, F15, F20. Could you just elaborate on that for the diuretic renography? You said your center, you follow F15, if I'm not mistaken.
Yeah, F0 is the baseline protocol, which is followed almost everywhere. So later there was a problem with the poorly functioning kidneys who were not showing up when they were given diuretic at the time of giving the radionuclide material. So what the nuclear medicine people thought is that why not keep the kidney already flushed while you were administering the radiopharmaceutical, so that at that time the kidney is having maximal filtration in the glomerulus and maximal drainage of urine, formation of urine into the PCS system. And with that F-15, you may be able to pick up more kidneys which are having less and less function. So that was a protocol which was designed for picking up the poorly functioning kidneys. So it may happen that we send a patient, he is subjected to a F0 protocol, and he comes back with a report that his kidney is not seen and it is non-functional. And then we will say, okay, why don't you do a F-15 protocol? And then he gets a test again, and then he will show some function, which will help us to take a decision that, yes, we should save this kidney and do a reconstructive procedure rather than doing a nephrectomy. So that is the idea between F0 and F-15.
So this would be the kidneys with like what, 10%, 15% function,
yes,
you're talking about?
Less than 10% function, less than 10%.
Dr. Diari, are we using the same protocols here?
Yes, F15, yeah.
F15.
Yes. Yeah. Or actually, this is a nuclear medicine protocol they are using.
Yeah, yes. Dr. Jundi?
Dr. Calavant is asking, what's the management of post-pyeloplasty leak? Is there any instances where we have to go in immediately as a surgical exploration?
Yeah, so what he's referring to is that you have done an anastomosis, you have done the suturing.
Yeah.
Now somehow it is not healing and there are gaps and urine is leaking out through that. it is very rare event to happen if you have placed a stent appropriately and the stent is draining. It is not going to happen. But if at all it happens, it is a reported complication. All you have to do is to put in a perinephric drain. That is the only thing which is needed. If you put in a drain, the urine is not getting collected either intraperitoneally or in the perinephric area. It just comes out. And with gradual natural healing of the anastomotic area, the leak is going to stop. It happens very, very rarely that you have to go and repeat the surgery and re-explore the patient and do the anastomosis. In fact, it is sometimes more damaging than being helpful. It is going, you will have so much of edema and scarring and other problems that it is going to have a lot of problems at that time. So it is not advisable. Just put in a drain and make sure that the stent is functional.
Yeah, I've seen fistulas close after 6 weeks actually.
Yes, they do.
Yeah.
Yeah, Dr. Jundi, as you remember, the worst part of that is the stent. When it is the 3 millimeter, it is only the holes are at the end.
Yes,
but
exactly.
3.7 and 4, it is side holes, which are much better.
Yeah.
And if there is any leak, you just regard it as a urethral injury when they are putting just a double J stent. So it will heal. It will heal.
Yeah. And I mean, there is no rush at all because you can consider it as a nephrostomy or ureterostomy. It leaks out and that's it.
Hardly you just need to put the perinephric drain and that's it. And it will
exactly. Yeah, I agree.
What are the other complications that one comes across post-pyeloplasty?
Recurrent stenosis at the anastomosis side, which is not common, but I'll let Dr. Diari and Dr. Ravi answer as well.
Sometimes if you are doing too much skeletonization of the ureter, you might make a vascular-like injury, and it might increase the length of the stricture. You might do a stricture. Might be by the laparoscopy that will be even less. The problem of maybe, Dr. Ravi, you correct me, the laparoscopy, if you are doing intraperitoneally and there is a leak, that will be a little bit worrisome. Retroperitoneally, there will be no problem.
Yeah, that's one of the theoretical points. But as I said, that leak is the incidence of leak is very, very less. And I mean, people doing laparoscopic pyeloplasties are actually, I would say that they have reached a point where they know how to anastomose the PUJ, and it can still happen. It can still happen, and I agree that pooling of urine is going to happen in the peritoneum, and it will be a little more generalized abdominal problem if the leak happens.
What approach do you use, Dr. Ravi? Anterior approach or loin approach?
You are asking for open pyeloplasty. Yeah, we do the anterior approach. We don't do that posterior or lumbotomy approach. We do the anterior approach, which is still retroperitoneal. So the peritoneum is swept away and we open the retroperitoneal area, but the patient lies supine, slightly rolled up. We have learned this from Dr. Rao. He used to do this almost 5 cases a day. So,
what is your experience in Dr. Ravi and Dr. Diari in our redo pyeloplasty? You will go in the same approach, or you will take any special precautions to do in redo pyeloplasty?
Yeah, redo, we get a lot of cases. Some of our own cases, we have had to do a redo pyeloplasty. And we get a lot of cases referred from outside where pyeloplasty has been done by somebody else and we have to redo them. I think the number would be at least 8 to 10 cases a year. And most of the time, the redo reasons for having a redo condition is that either they have not resected the enough segment of the bad ureter, which is supposed to go away, or there is a missed crossing vessel, which people have not picked up. Sometimes there is an anastomotic ischemic stricture, which needs to be revised. So redo is a problem.
So Ravi, 7-8 cases per year. I am working in this department, which is 60% of our work is urology. We have only 21 years, 1 patient from private. and it was totally misoriented. You know, they rotate the ureter.
Yeah, that's one of the common reasons.
Maybe
We are a country of billion
they are
people.
not coming to us. Maybe they are not coming to us. But to be honest with you, we did only one redo.
No,
Population.
We are a country of billion people, so there's no dearth of any kind of patient.
We will in redo pedoplasty, you will approach some other approach when you are done the retroperitoneum.
No.
Next time you'll go same approach, or you'll change your
Same
we can sum.
it was the lateral approach.
I think there was a question about approach from Dr. Martin, who said that not all physicians differentiate between laparoscopic and retroperitoneoscopic intervention. Do you actually use this retroperitoneal approach for pyeloplasties and other plastic approaches? So,
yes. So for the sake of clarity for our pediatrician colleagues, the renal pelvis can be approached through the peritoneum. So you just put in a scope through the umbilicus and you will see the renal pelvis on the left side and right side. The disadvantage with that is that you have to come across the entire bowel length. There is the colon, there is the mesentery, and you have to dissect and search the pelvis out of it. It's sometimes it becomes messy. So in order to avoid that, people started going through the back, where you enter the retroperitoneal space, enter the scope through a para vertebral area, just lateral to the edge of the quadratus lumborum muscle, and then you enter the retroperitoneum, and that way you don't see any bowel at all. What you see is just the kidney itself and the ureter. So it's a relatively neat field to work upon. The only problem is that it is little technically difficult to get into the correct retroperitoneal space. So we do quite a lot. In fact, I made a lot of teaching videos on how to create a retroperitoneal space and how to do a retroperitoneal pyeloplasty. And it all depends upon your technical expertise. If you are able to do it, retroperitoneal and transperitoneal are not very different, because once you're inside and your domain is established, the procedure is same in both the conditions. It is not different. And if you're comfortable with the retroperitoneal approach, it is very good. We have done quite a lot.
So is the patient prone in retroperitoneal?
He's lateral. He's like yes, lying on the side rather than.
So anesthesia wise, they don't have a problem.
Yeah, they don't have a problem.
We were on the topic of investigation. So in relation to that, you said IVP is an investigation of the past. Yeah, so what I wanted to know was that this used to be the most sought after investigation, more by surgeons than physicians, and invariably pre-op they would ask for an IVP. So what has replaced that? Is it CT? Is it MRI? What do you choose?
Yeah, IVP is a good investigation. I would say it provides a lot of information, both from the functional and structural aspect of the disease, of whether it is PUJ or whether it is duplex or whether it is reflux or any bladder problem. The problem of IPP was multiple X-ray exposures, and the dosage of radiation which the patient has to face is quite a lot. And since you are radiating him in the KUB area, pelvis area, metal radiation, which the patients were getting, and nobody knew that what was happening to these patients in the long run because of this radiation. So it got gradually replaced by the other more convenient investigations, and practically IVP is eliminated because of these radiations reasons. But it does give appropriate information otherwise. Now, most of the time, if you have to do this kind of investigation, MR urography is the go-to investigation. Even you don't do CT much. Very few people would do CT urography or a CT reconstruction. But MRI is the preferred if there is any reason to see the structure of the kidney.
One more question from the audience. How do you differentiate grade 4 hydronephrosis with multicystic dysplastic kidney?
Yeah, so multicystic dysplastic kidney occurs in two variants. One is the hydronephrotic variant and one is the atrophic variant. In atrophic variant, it just becomes like a lymph node and it just shrinks, so it is very clear. In the hydronephrotic variant, it will have multiple cortical cysts, which are actually not communicating with each other and not communicating with the renal pelvis. Whereas in hydronephrosis, it will be one big renal pelvic calyceal system dilatation, which is pressing on the renal parenchyma. And the renal cortex is normal but thinned out of pressure. But there are no renal cortical cysts. So that is how a radiologist is going to differentiate between a renal cortical MCDK and a severe hydronephrosis of grade 4 variety.
Yeah, the cat's paw sign, right?
Yeah.
And the best sensation, then you do DMSA, static isotope scan, then you can see that this is a hydronephrotic or this non-functioning kidney.
There are some
Yeah.
questions related to the conservative management of hydronephrosis. Dr. Pratibha Singh is asking, in a case of postnatal hydronephrosis, up to what AP diameter can be conservatively manage the infant? I think you have dealt this in detail,
10 mm.
but yes.
10 mm. This one, 10
And
mm.
another question was, for how long can we keep monitoring them conservatively?
Yeah, so as long as they are asymptomatic, if they are asymptomatic, you give the parents all the warning signs and symptoms. And if you feel that they are, they can come for surveillance and follow up, they can come. But, I would say that it is just first year, the maximum number of severe hydronephrosis which will require intervention will show up within the first year, and the remaining 50% are going to show up in the next year. So it is just the first 1 year or 2 year time period during which you have to keep them under follow-up, and you will know that how they are going to fare in long term and whether you want to operate or keep them on conservative management.
Right. Dr. Diari, the case that you showed was really scary. 4 years and missed to that extent, almost felt like no pediatrician ever touched the abdomen.
No, actually, because it is, just they diagnose him as abdominal distension, like gases and these things. And to be honest with you, it was missed. It was missed.
Yes.
Actually, he was not from UAE. He just came, from other country which they have a bad situation. So probably it was some reason like that. When he came here, also,
Right.
was not seen properly. Yeah.
So in these cases of hydronephrosis with deranged renal function, post pyeloplasty, what is the rate of fall of creatinine? How soon can we expect, or how late can we expect the kidney function to stabilize?
To be honest with
if
you,
it was all only due to obstruction.
In a unilateral hydronephrosis, creatinine urea electrolyte will be normal. There will be no problem with this. As Dr. Ravi mentioned, we are not doing any hematological or anything. Even we are not doing urine exam and urine culture for them on a routine basis. And usually when we are counseling the parents, we are telling them, when we are doing the surgery or pyeloplasty, we are stopping the damage. We are not regaining the function. That if it is a 30%, 35%, we will not make it 45%. We are just stopping the damage here. So they have to know this idea, not after that to come, they did not improve. Actually, sometimes, according to the isotope scan, there is an overestimation. So before surgery, you see it is 60%, while it is a PUJ 60% of the same side. Post-operatively, it will come 40% or even less. So overestimation is also another thing in isotope scan reading. So they are clearly knows that we are stopping the damage, not regaining the function.
What about newborns with PU valves with raised creatinine? In those cases, when you're doing the drainage procedures, be it vasicostomy, be it your upper system drainage, you do see a fall in creatinine, don't you?
We are doing serial, yes.
Yeah.
Usually, when you put a catheter, then they will regain if they are not having, high-grade reflux and dysplastic kidneys. Most of them, they will regain the function properly by age of 1 month. Sometimes, very unusually, we are doing vasicostomy or pylostomy. Most of the time, it is the resection or the incision of the valve, and that's it.
I think,
Dr. Venkatesh?
Probably that's it, and we'll give the floor to
He
Dr.
is very
Sarab
late in
to.
India now. It is almost, midnight.
Couple of questions still with me, doctor. So if you allow me,
If they are
Yes.
willing, you can ask. Doctor.
yes, Dr. Ravi, I hope he's willing to stay on
Oh,
for
yes,
5 more
absolutely.
minutes.
Absolutely. No problem.
Okay.
Go
No,
ahead.
I just I'm fascinated by the robotic surgery, really. So I wanted to ask you that other than hydronephrosis, in terms of urogenital system, what other cases have you dealt with? I want to know a little bit about your setup at PGI. Do you have pediatric urologists? Because frankly, here in UAE, everybody keeps asking for a pediatric urologist, all the time. So how do you manage? How have you all divided your work? Or is it pediatric surgeons who are taking special training and then dealing only with these cases? So these are certain things that I want to know from you.
Yeah, so about the spectrum of cases that we do robotically, it's quite wide. It ranges from all the, if I can list the urological procedures, it would include the nephrectomy, pyeloplasties, then reimplantations. We have done a lot of vesicoscopic robotic reimplantation, which is a very, scarcely done procedure. Very few people do it. And extravesical reimplantations, which we do. We do a lot of hepatobiliary procedures. So we have a published series of around 25 robotic polyducal cyst cases. So polyducal cyst is a very common procedure that we do at our place. We have dealt a few small tumors, suprarenal tumors through the robot. A few thoracoscopic procedures we have done. In fact, we have done a 2-day-old esophageal atresia repair with the robot. It was almost 2 years back, and that patient did quite well. And other than that, anything inside the abdomen which we get, we are able to do it with the robotic procedure. If there is a feasibility, we would offer him that things. So at our place, since the procedures are subsidized by the government, being a government institute, the patient has to pay a very, very nominal charge for the procedure. So say it is 10,000 rupees for a pyeloplasty, which is actually nothing. So people, if they are able to pay, and even if patients are not able to pay 10,000, we can arrange that from some NGOs and some charity, and they can get it done. The second question about the subspecialization of pediatric urology at our place. So far in India, pediatric urology is not yet a fully accredited specialty. It is just that the pediatric surgeons who are otherwise trained in the entire spectrum of pediatric surgery, they would themselves choose to do either pediatric urology or pediatric hepatobiliary or pediatric neurosurgery. They would do, say, there are few places which offer 1-year courses for these kind of subspecialties, and then these people would get those courses and come back and start doing pediatric urology. At our place, we have a lot of differentiation is now happening, but because of the caseload in our general work, we have to do everything. But whatever elective work which we have at our hand, we would try and choose our specialty. So I would do a lot of urology cases, but I do a lot of hepatobiliary also. But my special interest is mainly in the urology area. And similarly with my other colleagues, some would do mostly chest cases and thoracic cases, and somebody would do orthopedic, somebody would do neurosurgery cases. So that kind of arrangement is there. But you would not find an exclusive pediatric urology surgeon or an exclusive pediatric hepatobiliary surgeon. It's very rare to find. He would still be doing the other cases in his practice.
One question I want to interrupt. With the amount Dr. Ravi said, it comes to 500 dirham. One robotic surgery is about 500 dirham. I think from tomorrow, everybody will come to your center for this operation. It is
No,
very
those who
cheap.
go from here will be charged more, doctor. Okay, thank you so much. We learned a lot, and we hope to have Dr. Ravi in our future sessions with us.
Sure.
Really enjoyed
Thank you very much. I would like to take the opportunity to thank Professor Ravi, Dr. Diari, Dr. Ayman, Dr. Venkatesh, Dr. Kalpana, all viewers staying way up to this time. Our winner was Dr. Vivek Maheshwari from Kanpur. See, our winner is from India. They say, Sare Jahan se acha Hindustan hamara. So from India, we have winner. I would like to
Please
thank...
translate for Dr. Diari and Dr. Jundi. Sare jahan se acha Hindustan hamara.
I would like to thank Tawfiq and Fadi for sponsoring. Once again, all the viewers in future will request Dr. Ravi to join us more.
Definitely.
And I enjoyed, I learned many things really. So thank you very much, everybody. I would like to thank all the viewers.
Thank you. Thank you, Dr.
Thank
Ravi.
you.
Thank you.
Everybody, thank you very much.
It was a
Thank
pleasure
you.
to meet you.
Thank you and good night all.
Thank you.
Good night.
Thank you.
Shall we leave the meeting now, Dr.
Yes,
Saurabh?
doctor. Yes, doctor.
Yes,
Yes.
please, please. Thank you very much. Good night. Thank you.
Good night. Good night.